Hi, this is Jess Given with GDG Healthcare Architects. Today I want to talk about what goes into designing a compounding space, a clean room or a pharmacy for hospitals and for clinics. Regarding the history of pharmacies, I wanted to go back a step just to explain what USP 800 and USP 797 are regarding. In 2012, there was a compounding pharmacy on the East Coast. I won't name what state, and it had such poor practices that there was mold in the environment that the Board of Pharmacy literally had to rewrite codes to make sure that didn't happen. As a result of that pharmacy being so unsanitary, it was about 750 people got sick because it was a compounding pharmacy that distributed medications throughout various facilities throughout various states, and about 60 people died. So as a result, in 2016, the Board of Pharmacy rewrote the pharmaceutical code, and it was enforced in 2023. Now I want to break down USP 797 and USP 800 to help illustrate the requirements for each of those spaces. So for starters, USP 797 addresses pharmaceutical practices that are compounding non-hazardous drugs. And there's a whole list. There's a NIOSH list that identifies what the Board of Pharmacy in the United States recognizes as a potentially hazardous drug for the staff who's actually mixing these compounds, and certainly for the recipient receiving these compounds. The second regulation that came out in 2016 and became enforced in 2023 is USP 800, and that has to do with hazardous drug compounding. So those are all the elements that require special garbing just to be able to handle these products. And a lot of this stuff is dealing with infusion, oncology, and this sort of compounding TPNs. So every pharmacy that handles or compounds hazardous drugs is laid out in almost the same format. They start with an anteroom. In the anteroom, well, let me back up. They start with a main workroom. So this is where all your technical staff are sorting and storing and having shelves, often mobile shelves, for their pharmaceuticals, just like you'd see if you looked in a Walgreens. So looking at the floor plan, in the anteroom, the air is positive. So when you open the door, and by the way, all the doors are hands-free because there's no reason why you should be touching any of this stuff, because remember, this is an incredibly sterile environment. So you don't touch the door, you're garbed up, and you walk in to the anteroom and the air comes flowing at you. You stand there and you're inside the line of demarcation. That is a red line on the floor that basically says, do not cross until you're garbed up properly. So there's PPEs that are situated right on the side, and there's a bench where you can take the booty and put your booties on and put your foot down on the clean side and do that with the next leg, and then you stand up and now you're in the clean side. And from there you can go into the positive pressure or the negative pressure room. The positive pressure room is where non-compounding occurs, and so that would be positive to the anteroom. You open that door and the air again is going to be blowing at you. So I have a plus on the positive side and a plus on the anteroom side. And then if you were to go into the hazardous drug compounding room, which says right above that each of the spaces, the air would be going out of the anteroom and into the compound room. And the reason for that is because it's a hazardous materials that you're compounding, and a lot of that can be airborne or air rated. And so the biosafety cabinet, the BSC, has an exhaust vent, and that exhaust vent pulls the air out, and all of the ventilation system in the ceiling pulls all the air out. So there's no supply air. There's no return air. There's only exhaust air. Okay, so now that we've identified the three different segregated spaces, the anteroom, the positive pressure room, and the negative pressure room, the next step is, how is air brought into the space? And remember, USP 797, USP 800 are all about ventilation. So it's about positive air, how many air changes per hour, and filtered air, and where the air flows. So for example, if you have a box and the air is coming in and the return air is 10, 14 inches off the floor, or the return air is on the ceiling, it's just going to loop around like this, and you're going to have a whole dead spot down here on the bottom of the floor where bacteria could grow. In other words, you want airflow. It keeps anything from sticking, and it just goes directly through the ventilation system. So in this case, what we've designed is putting all the HEPA filters in the center of each room, and that way you have a laminar flow of air coming straight down like an air curtain. It hits the floor, it rolls around, and it comes up the walls. And before it can go any further up the walls, all the exhausts are down at the floor level. So the air goes directly like this. And you don't wind up with any dead spaces. You don't want to have any dead pockets in the airflow, because those are areas where bacteria can grow. And so again, keeping these environments as sterile as possible. So your air is coming directly down in a laminar flow pattern, and before it can turbulate and go back up and create jetties of little dead pockets that are going to occur, the exhaust air pulls it directly out. And so whether it's return air or exhaust air depends on the segregated type of room it is. So for example, if it is a HD, hazardous drug room that's in negative pressure, because it's hazardous drugs, there's no return air. It just goes, supply air comes in and exhaust air goes out. Constant supply of fresh, brand new supply air, and the exhaust air goes out, because the air could potentially be carrying something airborne, and that's what we're trying to avoid. In the anteroom, you can take your air and you can return it into the airflow, because in those cases, there's not a hazardous drug scenario. You're not compounding in that anteroom. Another topic that's really particular for pharmacy design is this. Think about it. Every 6 months, the pharmacy hoods and the pharmacy room itself needs to be inspected and certified. So the Board of Pharmacy said, hey, look, just because you're going to do it once right and you got approval and you got sign off, we want to make sure you continue to do it right. And so we want you to document the air changes per hour in every room. We want you to document the humidity in every room. And we want you to document the air pressure, the water column. So how much pressure is in that room. So negative and positive can fluctuate. You can be extremely negative and extremely positive, or it can be a minor, so it can be coming close. So they want to see what the air pressure in each of those rooms is. To do that, an inspection company has to come to your pharmacy. They have to put a cone over your HEPA filter and measure the air. What that does is it disrupts, and like you see in this diagram, there's 9 HEPA filters. So all 9 of those filters, each one of those would need to be checked. What that does in reality is it shuts that room down. It means that hospital is not able to function in that room because there's an inspector there measuring all the cones, and then you have to go and take a Q-tip, a wipe around the room, put it on a Petri dish, and then let it incubate for 2 weeks, and if something grows, the room failed. So you want nothing to grow after 2 weeks. And so that means the room is sterile. So what that means is you could potentially, if you're a hospital, you could potentially lose use of this space for quite some time. So what we've done is work with SEPA, and SEPA came up with a design that I believe they patented, where they take neoprene tubes connected to each one of the filters. They all come together in one plate, and they all have ports. And the tech can come into the room and check each of the ports and check the airflow rather than shutting the whole room down. So this can be done in 30 minutes compared to taking an entire day to lose the entire pharmacy, which is, it can be challenging. Another topic I wanted to address was garbing and doffing. So garbing is actually putting clothes on, doffing is taking them off. So when you're walking into a hazardous drug compounding area, before you can cross that line of demarcation, you have to pull out your garbing, your masks, your head cover, your gloves, your booties, and your full-on robe cover. You walk into the hazardous drug compounding area. When you come back out, you have to take all that and throw it in a trash bin before you exit the clean rooms entirely. So you can imagine, every time the tech goes in and out all day long, that's a lot of times putting on little plastic covers and then taking it all back off again, throwing it away, and then putting it back on again. So what we recommend and what we do for all of our pharmacies is we do pass-through windows on an airlock, so you can't just sit there and talk to each other through the pass-through, but only one door opens at a time, so the tech on the inside doesn't have to garb up and bring the product out. The tech on the inside can just open the door, put the product in the door, close it, and then the techs on the outside in the main pharmacy area, they can go right up to the pass-through window, open it from their side, grab the product, And so it saves a lot of time, becomes a lot more efficient. Last topic I wanted to just talk about real quickly. I mean, I could go on for days, honestly, because I really do love to talk about all the nuances and the intricacies that go into ventilation systems that are serving pharmaceutical areas. But one of the things that I thought would be important to share is you have an oncology clinic, an infusion clinic, and you have a hospital. They both have pharmacies. They both do compounding. The only difference is the Board of Pharmacy regulates the hospitals because hospitals tend to make product in bulk because they're getting prepared for patients. And those patients are getting prepared to give the product to those patients. For a clinic, those patients come in or they don't. Sometimes they are not feeling well enough to come in, but when they come in, the techs make it then in there right on the spot. And so the pharmaceutical code has a term called BUD, beyond use dating. So if it's within 12 hours of mixing it, they're not concerned about anything growing because it's going to go directly from that compounded product into that patient via TPN or something like that, so IV or something like that. So it's clinics don't have to be in lockstep with the full-on USP 800 regulations as a hospital does. So it really only starts to kick in when you start creating products that are going to be on the shelf for more than 12 hours. All right? Thank you.